Hello, everyone. It looks like the room is filling up. We'll wait just a couple minutes to let everyone come in, and I'll go over housekeeping and introductions, and we will get the show started. Thank you for joining us. The room is still filling up. All right, I'm gonna get started and just want to thank you. Good evening, and say thank you, everyone, for joining us today. We're grateful you're taking the time to join Northwest Parkinson's Foundation's new expert speaker series called Communities of PD Excellence, where together we build a stronger, more informed, and engaged Parkinson's community. If you don't know me, my name is Christine Pedigo, and I'm the Programs Director for Northwest Parkinson's Foundation. And today commences the second week of our 10-week local expert speaker series for Western Washington. With me is regional expert Dr. Laurie Mischley, naturopathic physician at Seattle Integrative Medicine and instructor of the online Parkinson School. Now, this expert speaker series is intended to be an open forum where you can actively engage each week with the local expert. If you would like to be added to the meeting room with us, please accept my invitation to let you in. I'll send those out shortly. Please note that we are recording each meeting and will post for viewing on our website. If you prefer to remain anonymous, simply decline my invitation. You may still ask Dr. Mischley questions via the chat function. To do so, click the chat button located at the bottom middle section of the Zoom window. Simply type your question and hit send. You also have the option of using closed captioning, which can be very helpful during the webinar. To activate it, look at the bottom of your Zoom screen and click the closed captioning button. Now, to introduce to you the esteemed Dr. Laurie Mischley. Laurie Mischley studied naturopathic medicine at Bastyr University and epidemiology and nutritional sciences at the University of Washington, where she maintains appointments at both universities. Her work is focused on identifying the nutritional requirements unique to individuals with Parkinson's disease and has published on coenzyme Q10, lithium, NAD+, and glutathione deficiency. She is principal investigator of the modifiable variables in Parkinsonism, the MVP study, which is attempting to describe why some people with PD progress slower than others. She is working on ways to study, package, and deliver evidence-based lifestyle modification as a therapeutic strategy. She founded the Parkinson Center for Pragmatic Research and the canine scent-based PD screening tool, PARC9. She developed a patient-reported outcome measure to assess PD severity, built the Parkinson symptom tracking app called ProPD, and is instructor of the online series Parkinson School. Dr. Mischley maintains a small clinic practice at Seattle Integrative Medicine, which is focused on nutrition and neurological health of patients with Parkinsonism. So without further ado, I now turn the spotlight over to you, Dr. Mischley, and I will allow people to come in and join the room with us.
Great. Hi, everybody. Thank you for the invitation to be here. And it's nice. I'm starting to see a couple familiar names, but I'm especially happy to see a whole bunch of new names here. That look good?
Yes, perfect.
Okay. So what I would like to do today is to introduce you, to the extent that I am able, some of the more unique parts of what we do. I think we are really lucky here in the Pacific Northwest to have the diversity of types of providers that care for people with Parkinson's. And I think we are better than most at intermingling and co-managing. So while probably what we have in common is more similar than dissimilar in terms of how we approach our patients, what our goals are, What I'm really intentionally doing here today is giving you a taste of what you might get differently at a naturopathic medical clinic or at one of our clinics. I think you just went through all my disclosures in the intro. So my goals for today's talk is that you leave this series realizing that you have a whole bunch more options than what you thought you had, right? That medicine is not just a pill for you to swallow, but the strategy you choose to employ. Your goal is to figure out what your game plan is and who's on your team. My goal is that your pro PD score is lower 1 year from now than it is today, and then it stays below 1,000 until your 100th birthday. Those are my goals. So before we get into me sharing my expertise with you, I just want to acknowledge that expertise comes in a lot of different forms. I don't have Parkinson's. You all have firsthand experience that brings to the table a level of expertise that I will never have. I've studied a lot. I've listened to thousands and thousands of patients tell me their stories, but there is a level of expertise I don't have. And I just want to acknowledge that what the goals here are not just what that literature says or what I think or what I've observed, but we have to come together with what I've observed, what I've studied, and what your experience is, what your goals are, what your lived experiences are. Even in evidence-based medicine, which is kind of all the rage these days, right? Like we want evidence-based medicine, and we use that term a lot, but I don't think people really appreciate what evidence-based medicine is. Evidence-based medicine is taking the best available evidence, but it also takes into account the physician's expertise and the patient's values and beliefs. So I just want to acknowledge that in medicine, in modern medicine, things move fast. You don't get a lot of time. One of the things that I just want to make sure we acknowledge is each one of you comes to the table with a different set of values and beliefs and goals and expectations, and that is going to influence how we treat you. So it's not one-stop shopping. It's the tools in the toolbox are catered to each person's desires. And one of the things that naturopathic medicine, or what I try to do in particular, integrative medicine, whatever you want to call it, is take into account not only your short-term goals and your long-term goals, but what are the resources that you have available to you? And resources include your support system, your motivation, your initiative, and any obstacles you're dealing with. Handicaps, financial scarcity, prior traumas, that all comes into play when we're deciding how to take care of you. So it's not about your tremor, it's you. My story starts in terms of how I started on this path and when I started. When I was maybe in 7th or 8th grade, my buddy, Brian Stibbets, his mom, you know, when you're in junior high, parents tell all the funny stories about when their kids were little. And we were talking about, I made some comment to Brian's mom. Did he always ask this many questions? Has he always been this annoying of a kid? And I remember what she said. She's like, are you kidding? Other kids ask, why is the sky blue? He never stopped there. There were 3 questions. Why is the sky blue? Who told you? And why do you believe them? Right? And to this day, he's now a lawyer in Alaska, you know, like who told you? Why do you believe them? That's why we were talking. I asked his permission to share his name. And he said, I still ask those questions, right? This is still my life. And what I want all of you to do, my goal here is just to disrupt the story you have been told, right? Don't, just because somebody tells you this is irreversible and progressive, just because somebody else hasn't been able to figure it out doesn't mean you won't be able to, or the next person won't be able to, or in the next couple of years, we won't be able to. So just be very careful about where you're getting your information and the faith that you put in them. So very briefly, what is a naturopathic doctor? No, it's not nice doctor. But that's the joke, haha. But naturopathic doctors are licensed primary care doctors in the state of Washington. We are licensed to diagnose, treat, manage, write prescriptions, order lab tests. While we can prescribe pharmaceutical drugs, you are much better off to get that done through your neurologist and primary care doc, or through your neurologist and movement disorder doc, 99% of the time. They're just better at med management. You're going to find a couple naturopathic docs who are unusually good at med management, but that's not generally how that's going to work. Same thing, you might find a movement disorder doc who's really, really good at diet and lifestyle, but generally speaking, naturopathic docs are going to be much better at counseling you on diet and exercise and supplements and lifestyle management. Of course, there are exceptions to every rule. Yes, we can overlap. We can all share these jobs, but I don't want any of you thinking that I'm saying that a naturopathic doc can and should do all of your Parkinson's disease management. I truly, truly believe we need a team, and in most cases, we want to take everybody's expertise. Your job here is to build your team, right? There's no right or wrong way to do it. Some of you are going to like Sally more than Bob. Some of you are going to like Bob more than Sally. It doesn't really matter. You have to find who your team is. Back to this concept of defining excellence. This is something I've actually personally gotten very passionate about. So I study epidemiologically, I study unorthodox ways to get information. And I'll talk to you about how I've been managing progression, but I have followed 3,000 people now for the last 10 years around the world. And we asked the question, in the last 6 months, would you say that your disease has gotten better, stayed the same, or gotten worse? Right? When I plotted that out by state, Washington State has more patients with Parkinson's saying, I have, in the last 6 months, my disease has improved than any other state that we are following. This is rough data. This was me messing around a couple nights ago. I haven't cleaned it. Maybe it's just all the rich organic food eaters in Washington. Maybe it's the great care we're prescribing. But, you know, in cancer, a lot of cancer statistics, I mean, a lot of facilities will say these are 5-year survival rates, 10-year survival rates by state. Why aren't we doing that in Parkinson's? Why isn't there competition between states, between clinics, between providers? Because, put physician egos on the line so that patients can benefit. If there's a patient down the road that's getting better results than I am, I would love to learn that. I would like to learn from them. They know something I don't know. So as we start defining excellence, I just want you to think bigger than what we have thought in the past. I would love for the next generation of Parkinson's care to actually be. Let's compare Oregon to Washington. Let's show the world that we can get better results than the rest of the states. I mean, I'm totally up for, I'm a competitive person. I don't know if we are doing something right. Maybe we're more delusional. I don't have a tremor. What are you talking about? I'm getting better. I mean, it could be that on an objective scale, that wouldn't be the same. And we don't actually know how reliable these outcome measures are. So we have work to do on this thread going down this road, but I love this idea of actually putting patients and patient outcomes in first place and starting to change our practice to get better and better patient outcomes. So naturopathic medicine is kind of this jack of all trades, master of none. We learn anatomy and physiology and histology and all the basic sciences like any other medical school, but where conventional docs start doing rotations through gynecology and minor surgery and all of that stuff, we kind of get all integrated. We learn chiropractic adjustments and counseling and pharmaceuticals and minor surgery and chiropractic adjustments and hydrotherapy. And so it's kind of this jack of all trades, master of none sort of approach. And the idea is eclectic, take the best of all practice philosophies and implement them. It's great in theory, but it's hard to be really good at any one thing. But so when we're talking about naturopathic medicine, we're not just talking about tools in the toolbox, but philosophical differences. Simply, I would say it's pretty fair to think of what you're doing with your conventional neurologist for Parkinson's care as largely defensive. It's kind of palliative, like you're going to get worse, you keep having symptoms, and our job is just to hide them while you go down. We try to minimize your suffering. And it's great. I mean, it's the best we have. We've come a long way. We're so much better today than we were 50 years ago. Huge improvements over the last 50 years, but it's still not good enough. I mean, we're 200 years in, and the best we can do is we'll try to make you feel better while you decompose. We can do better. And so what I'm representing here is more of an offensive strategy. Like, how'd you get here? What can we do about it? Can we do something more aggressively, assertively to change what your future is going to look like? You've got to rock the boat a little bit if you want a different outcome. If you keep doing the same things over and over and over, you're going to get the same results. I'm purposely here to point out some of the biggest differences between what I do and what other docs do. I don't think everyone's going to do it. I might be wrong about some of this stuff, but I am really discontent with the fact that we are 200 years into this disease and we don't know what caused it. We don't know how to fix it. We don't know how to slow it. We don't know how to predict it. We don't know how to stop it. We don't know how to reverse it. The current strategy isn't working, so I'm here to advocate for trying something else. So I think the unorthodoxy of what I'm bringing to the table, it starts before we even meet. Before people schedule their first visit, we have them go to Parkinson School and watch a free orientation video that describes my shtick, where my information is coming from, what the research is that I'm doing, what my training is, and what my goals are. I have all my patients download a Parkinson symptom tracking app. It's freely available on iOS and Android. And all of my patients generate a Pro PD report. And before my patients walk in the front door, they do a PD panel of testing. It costs about $300. Sometimes insurance pays for it. Most people just pay out of pocket. But this is what I feel enables me to take the best care of patients, fastest, most concisely, save the most money, get the most benefit in the shortest amount of time. So before we even meet, I've already can look at your Pro PD report. I can see your labs before you walk into my office. I don't have to waste my time introducing my philosophy. I've already reviewed all your stuff. I know what your biggest complaints are. I know where the holes are in your metabolism. I know if you have B12 deficiency, vitamin D deficiency, high blood sugar, high inflammation, and I know how you compare to your peers. The other thing is my office staff is amazing. By the time I've seen them, they've already cracked a joke. They've already laughed. They're personable, they're smart, they're respectful. Probably 2/3 of my patients, unprompted, compliment me on our staff. There's therapeutic value in that, right? On the days, my office manager will tell people when they turn in their Pro PD scores, if it's not better in a year, fire Laurie. Before I've even met them, my staff has planted the seed in their head. You mean reverse? You mean I could be better in a year? My other doc just told me this was irreversible and progressive. And now I've got this team over here saying it might not have to, right? That's therapeutic. I have trained 2 Italian truffle hunting dogs, Lagotto Romagnolo, to smell Parkinson's. On my clinic days in person, I tend to bring one of them into the clinic. It's a lot cheaper and faster than a DAT scan. My dogs will go around the office and smell the ankles of the people in the waiting room and sit at the foot of people who have the scent of Parkinson's. So once a week, I bring a dog, and that probably falls in the unorthodox environment category someplace. I don't think that's something I would expect anyone else to do, but that's something unusual about our clinic. We're in the beta testing. This isn't for sale. It's not available. It's not anything. I'm working on the science behind the scenes, but the dogs really don't ever miss a positive. But about 27% of the time, they call a negative positive. They can't tell the difference between Parkinson's and Alzheimer's. They can't tell that. They call MSA, Lewy body dementia, PSP, they call that all positive. They say yes to any neurodegenerative disease. So what we don't know is why this specificity is so low. Are they smelling something unrelated? Are these people that we're saying the dogs were wrong? Are all these people going to be diagnosed in the next 10 years? Maybe the dogs are right and they're smelling it 10 years before we're seeing symptoms. So I'm not comfortable. I just don't know enough about this diminished low sense specificity, but that's happening with the dogs. Then in the clinic, just like any other doc, what are your priorities? What are your limitations? What are your personal goals? That's not that different than what any other doctor does, I think. For those of you who are unfamiliar with the Parkinson Symptom Tracking app, let me just talk to you about this for a second. We built the scale 10 years ago for a particular study. We needed an outcome measure that could track Parkinson's progression remotely. And so we built this scale, and I'm very proud to say in 2023, a group in Sweden did this amazing study. They brought every 4th person in Sweden with Parkinson's in for 3 years, every 6 months for 3 years, and gave them an entire battery of tests, and concluded that the Parkinson's symptom tracking, this Pro PD scale, is awesome at tracking Parkinson's progression in the first 10 years, 15 years of disease. I'm not sure about late stage, but early on, this is more sensitive than the UPDRS. So I am very excited that we finally had, I mean, do you realize how crazy it is that we are 200 years into this disease and everyone wants to slow progression, but we don't actually have a tool that measures progression? Like UPDRS, we use it for research studies, and yes, it gets better in response to levodopa, but it's not clinically relevant. Your neurologist is never like, oh, geez, Bob, it's so good you got your UPDRS down 2 points. Like, we don't use it like that because it doesn't work like that. It doesn't have the clinical relevance we need it to have. Like, there's not a person in the world who will tell you that that reflects their disease. So we've been using this outcome measure that isn't very clinically relevant. So now we have an outcome measure that's clinically relevant. It's free. You can download your app. And so every one of my patients gets one of these reports before they come in the front door. This is what the average rate of progression looks like. I don't see if you can you see my cursor? Yeah. So the average rate of progression, most people diagnose at about 500 and go up about 40 points a year. So this person, before they even came in, I can see they're doing better than average. I can see what their primary symptoms are. I can see in which domain they're having their symptoms. So this helps me take much better care of patients, and it actually also puts the patient in the driver's seat. It's not about the tremor I see, it's about the symptoms you're experiencing, right? And I just want to talk about that. I mean, as a developer of a patient-reported outcome, I cannot tell you the number of times neurologists or other scientists, I won't say neurologists, or scientists in general, will respond to this as, but it's only subjective. And I'm like, as opposed to your objective measure of apathy? I mean, as opposed to your objective measure of a patient's anxiety? I was meeting with a collaborator colleague, and there was a thing that said sexual dysfunction, and women in this group had an unusually high sexual dysfunction score. He was like, yeah, but it's only subjective. I was like, are you saying that you don't trust a woman to be able to tell you whether or not she has sexual dysfunction or not? Like, it's a crazy concept that we would downgrade a subjective outcome measure because we think we are more able to measure your symptom severity than the patient. The subjective experience, the patient-reported outcome, should be the gold standard. We should be doing everything in our power to getting your patient-reported outcome score as good as possible. So this patient was really great. This is a patient I met yesterday, and it was really fun to have never met her before. And I can already see the journey she's been on. I can see her getting worse. I can see all these little comments she's made. This is the first time I'm submitting a score. I wasn't very honest a couple days ago, so I'm filling it out again, right? You know, my 743, if I'm being honest, is more like a 1100. And then look at, she goes from 1,000 to 600. I've been on levodopa for 1 month. Look at the improvement in her score. This was her before starting levodopa. This is her after levodopa. It is so rewarding and empowering and motivating for patients to start to see their scores get better. I don't care if it's from levodopa or exercise or supplements or a good night's sleep. I'm telling you, when people start to see that they can get better, they start to believe they can get better, and they start doing more things to start to chase, what do I need to do to make that score go down? I don't actually know how to do the study. I'm a little stumped there, but I actually think the act of just keeping your score probably keeps your score better. It's taking the time to get your head out of the sand, have a little heart-to-heart with yourself about how symptomatic are you, what are your priorities, what is bothersome. So anyway, for other providers who happen to be listening to this talk as of this week, this outcome measure, there's a way for other physicians to set up an account, and they can start to follow their own patients' pro-PD scores over time. So this is not something that's only to me. Now other providers can officially start using this too. Okay, so now we're getting into the nitty-gritty. So I call it, my degree is in naturopathic medicine, but philosophically, I'm probably more aligned with something called orthomolecular medicine. And this is just basically, this is a term coined by Linus Pauling. He's the only person in history to win 2 unshared Nobel Prizes. And he basically just defined the term orthomolecular. And the idea was the right amount in the right dose. Not all humans are exactly the same. You know, the way a pregnant woman needs more folic acid, or a burn victim needs more protein, or a tobacco smoker needs higher vitamin C requirements. So might somebody with Parkinson's have higher requirements of all different types of nutrients, right? And so really, it's super simple. Do you have everything do you need? And could there be something that's getting in the way of the body working the way it's supposed to? In modern medicine, this would probably be broken up into nutritional medicine and environmental medicine, but it's a super simple concept. And that's kind of what we're trying to work our way through. It's a systems approach, right? It's not just you're low in dopamine, take more dopamine. The gut, mind, brain, anatomy, physiology, immunology, histology, environmental stress, coping skills, childhood trauma, glutathione, fish oil, DHA, norepinephrine, serotonin, DHEA. There's an orchestra. These things are all interrelated, interconnected, and you do need some help figuring out how to manage them. It's not just take more dopamine, I'll see you in 6 months. That's not going to cut it in something as complicated as Parkinson's. For those of you with attention deficit disorder who are already sick of hearing me talk, this is everything I know. This is the cheat sheet. This is 10 years of my work. I already showed you the average person with Parkinson's progresses at about this rate. Let's just talk about this for a minute. Statistically, no one likes hearing this, but data is the data. Most people get about 10 good years. And for perspective, back in 1975, the average person with Parkinson's died with eight years of diagnosis. We have come a really, really, really long way. I know this is not the curve that any of you want to see, but I want to let you know it's already so much better than it used to be. And there is no reason to believe that we can't continue to make it better. I will tell you, we have people from over 150 countries already joining or using this app. Geographically, it is gut-wrenching, heartbreaking to see how much worse people are in other parts of the world. As bad as Parkinson's is here, you cannot believe how lucky we are compared to what is happening in other geographic locations. So we'll get into some of the nitty-gritty about this, but I'll just tell you, it's taken me 10 years, 2 doctorates, and a master's, and I don't want to count up the amount of money I've spent on schooling to tell you that lonely, poor, lazy people with a lot of stress who eat a lot of canned food, fried food, soda, meat, cheese, frozen vegetables, bread, pasta, and juice do better than people who have money, friends, exercise a lot, have a stress management practice, eat a lot of fruits, veggies, nuts and seeds, non-fried fish, beans, olive oil, coconut oil, fresh herbs, spices, and prefer to cook and eat most of their meals at home. We'll talk about supplements in a minute, but it's not there's nothing shocking here. I mean, when I tell people fruits and veggies and nuts and seeds and fish and beans and olive oil and herbs and spices are good for them, nobody questions that. When I tell people they should stop eating cheese, that's only observational data. You know, like you might not like the data, but the data is the data. This is not my opinion. We can tell you with 95% confidence, the more of these foods a person eats, the faster their disease progresses. The more of these things a person does, the slower the rate of progression. Until we have a cure, my approach to medicine is don't do this, do lots of this. Exercise. I'm going to blow through some of this stuff kind of fast because I know you have physical therapists working on doing this series too, and people who know a lot more than me. Absolutely, every single person, I tell them they need at least 30 minutes a day. That's what our data is, because that's how we set up the study. According to our data, the first 2 days a week do not count to slow Parkinson's progression. People who say, I do 30 minutes of exercise twice a week are not progressing any slower than people who do not exercise at all. It's not to say they don't count. I'm sure they might make a little dopamine, get a little circulation, start to build some new habits. But in terms of real statistically significant impact, it's not working. You need to get to 3 days a week to actually start to see measurable, meaningful change in rate of progression. 4 days is better than 3, 5 is better than 4, 6 is better than 5, 7 is better than 6. Every one of you has to decide how bad do you want it. The more you do, the slower the disease seems to be progressing. I'm a little lazy. I'm kind of going to cut my losses. I'll take 6 days a week. I'll take the day off. I'll eat a couple extra vegetables and make up for those 7 points. That's not enough of a, some people are like, are you kidding? I'm going to do 7 days a week, twice a day. Every one of you kind of has to decide how bad you want it. So I ask all of my patients to have a very, very, very committed exercise routine, to work with physical therapists, to join all these amazing things that Seattle has to offer. My ask is that they work to make their exercise activities physically intense, cognitively challenging, outside your comfort zone, and so difficult that you're getting frustrated and making mistakes. My goal is not just increasing heart rate and sweat and blood flow, but I'm also working for neuroplasticity. The more you exercise, the more your brain makes these growth factors that tell your neurons to start sprouting. And the more foreign it is, the more awkward, the more uncomfortable, the more frustrated you get, the more growth factor you make, and your entire brain gets the benefit of that fertilizer. So you really want to push your comfort level. And like I said, I'm a little lazy. I'm strategic. One-stop shopping. Pickleball checks every one of those. Like you get all of those things. You're social. It's cognitively challenging. It's outside your comfort zone. You're getting frustrated. You're making mistakes. There's peer pressure. So it doesn't, there are lots of clever ways. I do think environmental medicine is a very important part of medicine. I think it's one of the most overlooked parts of medicine. It is not my strong suit. This is not something I spend a lot of time on, but I think a good doctor, a good integrative medicine doctor, is going to really make sure that you're not putting too much in that could be causing problems. I certainly cover the diet aspects. Dairy, aspartame, fried foods have a chemical called acrolein that causes protein misfolding. Iron can be problematic, certainly pesticides, loneliness. The single question, do you ever feel left out, is the single best screening test for loneliness in Parkinson's disease. I think that's an important question to ask patients. Air, water, molds, messed up circadian rhythms. There are all kinds of things we are being exposed to on a regular basis that are interfering with our ability to find health. So I think making sure that somebody, some way, somehow is addressing some of this stuff. Again, this is 10 years of my life work on a piece of paper. This is all of the answer key to the food stuff. I will make this sheet available, but what I want to convey is, kindergarten level is, hey, these foods are bad, don't eat them. These foods are good, do eat them. Eventually I will turn this into an app, but what the data suggests is that if you add up all of your points, your bad points, subtract all of your good points and get a 0, you will progress like a normal person. If you're a plus 300, you're going to progress faster. If you're a minus 300, you're going to progress slower. So I don't expect anyone to carry this sheet around and do math, like they're Weight Watchers. But I do think it's a good exercise to sit down with this list and have a little conversation with yourself. How often do I eat fruit from a can? Most people say, oh, never, never. And they're thinking mandarin oranges in their can opener, right? But the reality is every time you have a piece of pizza, you are eating fruit from a can. That tomato paste is fruit from a can. I lost a bunch of fruit from a can points for, I do once a week, I do Thai takeout, coconut curry. The coconut milk is fruit from a can. Fried food, I lost a surprising number of points for my corn chips, my corn tortillas. I don't know why I wanted them to not be fried. I wanted them to be baked, but they're not. I'm dipping them in good stuff, guacamole, pico de gallo, but they're not, they're fried. So what this data is basically saying, let me just show you how to use this. If you eat French fries once a week, fried food is 34 points. Once a week, you multiply it by 4. 34 times 4 is 136. A person who eats French fries once a week is going to score on average about 136 points more symptomatic than a person who does not eat French fries once a week. It adds up faster than you think. And again, none of this is my opinion. I'm the messenger. I just went out and surveyed thousands of people with Parkinson's, and we can tell you with 95% confidence, the more of this food you eat, the more likely you are to be in the fast progressing group. The more of this food you eat, the more likely you are to be in the non-progressing group. My advice is don't eat this and eat lots and lots of this. And the other thing is, I think once you start to play with it, it's easy to start to get competitive. I mean, just in the last couple months, do you know how easy it is to have an apple and peanut butter as a snack or some cucumbers and hummus? Not only do you get points for the apple or for the carrots and the cucumbers that you're dipping in the hummus, but I get the bean points, the garbanzo beans. I give myself tahini points, lemon juice points, olive juice points, put a little extra paprika in there. Pretty soon, cucumbers and hummus and an apple and peanut butter as a snack throughout the day just got you an extra 200 points to the good. So I don't think this is as bad as people realize. I think it can be fun. We can work on cookbooks, and it's a Mediterranean diet. I mean, there's nothing on here that's surprising. And as much as people go kicking and screaming, like they don't want to give up their pasta and their bread and their chicken, and they want to know why drinking from plastic bottles is bad. And I actually don't know. It could just be that poor people eat more fruit from a can. But we have adjusted these data for age, income, gender, and years since diagnosis. So we have done our best to take that into account. I am sure that you cannot drink red wine your way into disease modification. Like, even though people who do the best drink more red wine, I don't believe that you can drink enough red wine to make your disease stop progressing. This probably isn't about the red wine, but the type of person who drinks red wine. And again, I don't have the answer, but I'm telling you, you should, whatever those people are doing, you should do that too. Because they're doing better than you, right? Like and if you don't drink, don't start drinking. I mean, I don't think you need to do all of these things. And the other thing I will just say is I cheat. I'm not a purist. I don't think you have to be 100% never, ever, ever touch these things, but you have to earn your cheating. I can make a smoothie that has most of this stuff in it in the morning. I mean, I get most of my fruits and veggies and nuts and seeds in my morning smoothie. If you're coming in at minus 500 points, who cares if there are a little fried corn chips on your taco salad? But big picture, I think it's a really good idea to learn to not have these foods up top as part of your diet. And again, dairy, very, very consistent. Independently, ice cream, butter, cheese, yogurt, milk. All the meats, chicken, pork, and beef. For whatever reason, turkey has always been neutral. People are going to ask, eggs are fine. Eggs don't seem to be a problem. Turkey doesn't seem to be a problem. Frozen fruit is fine, but for some reason, frozen vegetables were associated with worse outcomes. Bread and pasta, I know I'm going to spend the next couple of years asking me, what about gluten-free? We just don't know. But I think you're not doing yourself any favors by pasta and bread. I think as soon as you turn that whole grain to flour, you lose a lot of the nutritional value and the ability to do good stuff for your gut microbiome. So, and it's probably taking up a lot of space that should go to this stuff. So I don't think it's the end of the world if, you have an occasional piece of avocado toast, but I would not make bread and pasta a staple in your diet. We already talked about med management. I don't want to get into med management too much, but I will just say I have strong opinions about don't skimp. I see so many people who come to me because they want an alternative to the levodopa. L-dopa deficiency is a nutritional deficiency just like anything else. You need to put gas in the tank. You need to take levodopa, and you are not doing yourself any favors to play, what happens if I only put a little teeny bit of gas in the tank? Give your body what it needs, work with your doc. You're not going to hurt yourself to go a little over or under. We can fine tune it over time, but less is not more. But more is not more either. I mean, there's a sweet spot. I see a lot of people who are scared to death of levodopa, and they need to not be. Take your medications on a schedule with an alarm. It works best if you set an alarm that isn't an annoying sound and you don't turn it off until you've swallowed your pill. We are Pavlov's dogs, and you will actually get better bang for your buck out of your meds if you start to partner it with a routine and a sound. And then protein redistribution diets are pretty important. There are a lot of people, I think I have a diet, for those of you who don't know, the levodopa is absorbed through amino acid receptors in your gut. So the same receptors that absorb your dietary protein also absorb your levodopa. So if you wake up in the morning and have an omelet or have a turkey sandwich for lunch, for a lot of people, your first protein-containing meal of the day is the beginning of your meds not working well for the rest of the day. And that can really throw people off. And so what a protein redistribution diet is you're still allowed to have a little protein throughout the day, but you save most of it for dinner. You have a lower protein breakfast, a lower protein lunch, and then most of your protein at dinner. After your dinner meal, your meds are not going to work as well. You're going to be a little more stiff, a little more rigid, but this is a way to kind of have your cake and eat it too. You let your meds get first dibs for the majority of the day, go to your exercise class, run your errands, go to work. And then in the evening, you have to get protein. We need you to get protein. That might be a good time to use one of these, anyway, rescue meds or something. For those of you who are wondering, could my food be interfering with my meds working well? A couple hints. If your first pill of the day is the one that works best, people will often say my morning medicine works really well, and then it becomes a little more hit or miss as the day goes on. And then we have an amazing dietitian at our office, and she has this 4-day low protein diet that she will put people on. And, by day 3, the golfers are all coming in, bringing us flowers. Like, you would not believe how much, this is what on feels like. Are you kidding me? This is what levodopa is supposed to feel like. And so if after 4 days of low protein, you're no better, then go back to eating protein. That's not your problem. But if all of a sudden you go on a low protein diet and, the clouds part and the angels start singing and your golf game improves, then you're probably one of these people suffering from this interaction, and we will put you on a protein redistribution diet. Make sure you get enough protein, but allow your meds to work. The other really important food medication interaction that I think does not get enough attention is levodopa interferes with your body's ability to absorb some B vitamins. That raises your homocysteine levels, and that raises your risk of dementia. In my heart of hearts, I believe a whole bunch of the dementia that we see people have with Parkinson's is because of the medicines that we are giving them, and we are not doing our job treating the medication side effects. We have known for 30 years, the head honcho at Mayo just published last year a great article, Levodopa, Homocysteine, and Parkinson's. What's the problem? If I may paraphrase, he is saying we have 25 years of data that the medicine we are giving you is raising your homocysteine, and that is contributing to your dementia. If we are going to prescribe levodopa, which we should prescribe it, you should take it, just take a B vitamin with it. Every single person on levodopa either needs a B vitamin, or even better, they need to measure their homocysteine and keep it below 10. So there are a whole bunch of reasons. And I'm going to get into labs, because this is one thing that I think is really, really, really important in Parkinson's care. And I don't think many docs are doing labs for people with Parkinson's today. So there are a whole bunch of things that can cause homocysteine to be high. And what we are worried about is high homocysteine makes your Parkinson's progress faster, up to 4 times the rate of cognitive decline, can lead to peripheral neuropathy, and we're not sure about cardiovascular risk. But there are a whole bunch of ways to get to high homocysteine. And the one that I'm talking to you about today, I mean, many of you have the elderly thing going on. You have the malabsorption thing going on. Some of you have the alcohol thing going on. Some of you are on reflux meds and bariatric surgery folks. That's all real, but even more relevant is if you are taking carbidopa, levodopa, we know for a fact it's interfering with your body's ability to absorb and utilize folate, B12, and B6. That's going to raise your homocysteine level, and you're in this situation. So, and when we surveyed in the 2022, when we surveyed 1,100 people and said, what supplements are you taking? The people who said, I am taking a homocysteine lowering B vitamin, there were 129 out of them out of 1,100, and they were statistically significantly having a slower progressing disease than the people not taking homocysteine lowering vitamins. So we are finally starting to get somewhere. So this is just something that I hear come up a lot, and this is probably, I may be talking more to the other docs than to the patients, but I think we just need to have it out. So if you order a serum B12 test, the reference range says 200 to 1100. That is for the general population, and I would argue that is way, 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 way too low. But that's besides the point. Normal is 200 to 1100. Well, let's look at the Parkinson's specific reference range. This is, they took a bunch of people with Parkinson's, measured their B12 levels, broke them up into 3 categories: less than 400, 400 to 600, or greater than 600. And what we are looking at here is your risk of remaining dementia-free. So for people who had a B12 level less than 400, there was a 0% chance that they were dementia-free 9 years following diagnosis. That's the normal reference range. For people 400 to 600, oh, lucky them, 17% chance of being dementia-free. That's high normal. I'm telling you, nobody should ever be below 700, ever. Just getting your B12 levels up above 627 bumps your likelihood of being dementia-free up to 65%. What are we doing that we are not screening every new patient for their B12 levels? Do you know how many people we could be preventing dementia from if we would just start treating their underlying nutritional deficiencies? Okay, enough of that soapbox. The other thing is, I guess it's not enough of that soapbox. I have more to say. The other thing is what I don't think a lot of people realize is B12 deficiency can cause a tremor and Parkinsonian symptoms. B12 deficiency kills dopamine neurons. I learned this in my nutrition undergrad. I learned this in nutrition PhD. I don't know why the neurologists don't see a person with Parkinson's and say, I want to make sure this isn't caused by B12 deficiency. So this is part of what and again, this is what I do. Other people are going to be better at other stuff. And this gets into this big world of what biomarkers do you go looking for? You could easily spend $3,000 like that looking under every rock, looking for mycotoxins, urine organic acids, all kinds of crazy stuff that may or may not be relevant. And this is why you need to work with somebody who knows what they're talking about, because I don't want you going on a fishing expedition and a goose chase, spending thousands of dollars looking for lab abnormalities that aren't relevant. So while lots and lots of labs are abnormal, what you're working with a trained doc to do is help you figure out where's the best bang for your buck. So as I said, I have a laboratory workup. This is what the panel that I do on all of my patients. Every single one of the measures on this panel has been linked to better or worse Parkinson's outcomes. We know the lower your uric acid, the faster your disease progresses. People with low vitamin D have more constipation, worse balance, worse muscle strength, more dementia, more osteoporosis, more depression. People with high omega-3 fatty acid levels have less cognitive decline. So I know exactly what I'm looking for when I ask for all of these tests. And then I also do a hair test where I look for hair lithium deficiency. My master's research is on the role, just like the body needs calcium and magnesium and sodium and potassium, so does every cell in the body need lithium. Neurons need a ton of lithium. And we have known for about 20 years, 30 years now, the data has been building that the lower the lithium in any region, the more psychiatric problems we have, the more suicides, the more psychosis, the more impulse control disorders, because neurons need a lot of lithium to be healthy. And a lot of places around the United States have low lithium in the water supply. So I started studying lithium deficiency in Parkinson's disease, and it just so happens the only way to measure lithium is in the hair. So I also ask my patients to do a hair test so I can see if they have lithium deficiency, because the Pacific Northwest is very low in lithium. One of the other labs that I look at in terms of the panel is inflammation. I think this is maybe a $12 test. It's really easy to order. Any doctor can order it. But again, what we looked at is newly diagnosed people with Parkinson's. We measured their amount of inflammation. On the lab slip, anything less than a 1 is considered healthy. In the Parkinson's world, 0.8 seems to be the number that we're after. But what we are looking at here is if at diagnosis, your CRP, your inflammation level, is less than a 0.8, there is a 70% chance you are still alive 10 years from now. For the people who had an inflammation level greater than 0.8, there is only a 45% chance they are still alive 10 years from now. That is a really big difference. Those numbers are huge. Like, if you are inflamed, I think you should make it a priority to figure out where that inflammation is coming from and eradicate it. If it's your Big Macs and cheeseburgers, stop. If it's your high blood sugar, your diabetes, get it down. You know, if you're smoking too many cigarettes or too much crack, stop. Like, whatever you are doing that's making you inflamed, let's chase it, let's identify it, and let's stop it, because people who are inflamed do worse over time. And again, it's a $12 test. I think everybody with Parkinson's should know how inflamed they are. Once a year, get the test. Last lab test I think I'm going to talk about, and I just, again, want to say this to rock the boat. We are in this habit. It's not so bad in Seattle anymore. We've got some really good docs here in town, but there was a period where anybody who had a slightly elevated cholesterol was put on a statin. And it is true that the higher your cholesterol, the more likely you are to die from heart disease. That's a true statement. But what often gets overlooked is cholesterol is a U-shaped curve. The lower your cholesterol, the more likely you are to die from all kinds of other stuff, infections, cancers, other things. So cholesterol is a U-shaped curve. I don't want you too high, but nor do I want you too low. And this is especially relevant in Parkinson's disease because for a lot of reasons, high cholesterol seems to be protective against Parkinson's. People with low cholesterol seem to progress faster, get more dementia than people who have high cholesterol. And so that doesn't mean I want everyone to go out and start trying to do everything they can to raise their cholesterol. But it does mean that it's not as simple as, hey, Bob, your cholesterol's a 220, here's a statin, see you later. People who have Parkinson's and cholesterol issues have to think through the choice to use a statin a little bit more than the average person, because I really do believe the data suggests that low cholesterol is worse for people with Parkinson's. I make jokes in clinic. What do you like more, your brain or your heart, right? It's not easy and there's no right answer. There are some people who should be on a statin. There are some people who shouldn't. And that's just a conversation for you to have with your cardiologist. But I really want to make sure that whoever's prescribing your statins is very, very, very familiar with the research on statins and Parkinson's and low cholesterol in Parkinson's, and is, having a very educated decision with you about, hey, you are such a ticking time bomb for cardiovascular disease that it is worth the risk to your Parkinson's, or vice versa. But these are complicated conversations for patients to have with their doc, and it's not one size fits all. In terms of supplements, I think that's probably the other thing that we do differently is we use supplements, we're trained in supplements. I did this publication last year. Like I said, I interviewed 1,100 people. These are the most common supplements people are taking. They are not the ones that work. Probiotics don't work to slow progression. Multivitamins, calcium, melatonin are not working to slow progression. The rest of these actually are. So this paper is available free online. It's easy to get. I'll put the references are available. But just for anybody who wants kind of an overview, what we did is we looked to see, are there any supplements associated with slower Parkinson's progression? Let me just give you all a quick little tutorial on how to read this. There were 1,100 people in the study. 19 of them said, I have been taking ginkgo consistently for at least the last 6 months. Those 19 people, their pro-PD scores were 357 points better than the other people not taking ginkgo. And the black line tells us how confident are we in those data. If we were to study another population in another place, that this blue line would actually be somewhere between here and here. It's still good. I mean, those 19 people taking ginkgo are doing pretty well, but there's never been a human study where we give people with Parkinson's ginkgo. That's not strong enough data for me to jump on the ginkgo bandwagon and ask all my patients to start taking ginkgo. I promise you, these 19 people are doing a lot of other stuff too. They're exercising, they're drinking their green tea, they're taking other supplements. But once we start getting into hundreds of people taking glutathione, CoQ10, low-dose lithium, turmeric, Where we have 100+ people taking it and it's still statistically significant, that's kind of the toolbox. Like for those of you who are asking the question, should I be taking some supplements to slow my progression? CoQ10 looks like a pretty good bet. Glutathione looks like a pretty good bet. You know how cheap vitamin C is? Even vitamin C seems to be working. Fish oil seems to be slowing progression. Coconut oil is working. It makes some fat bombs. Saute your veggies in coconut oil. It's easy to slip some of this stuff in. Some of this stuff is contraindicated. If you had breast cancer or prostate cancer, you could actually hurt yourself by taking DHEA. This isn't a shopping list. These are medicines, just like anything else. And you need somebody who knows what they're talking about, who's trained in these medicines to help you figure out what is a waste of money and what looks like it might be a good idea. For those of you who don't have a lot of experience with supplements, 50% of what is sold over the counter does not have in it what the label says it has in it. Quality control is a nightmare when it comes to supplements. Because it takes a long time to get into doctors, the waiting lists are long, healthcare is expensive, it's hard to come in one-on-one. About 4 or 5 years ago, I started dumping everything. Instead of writing a book talking about what I think and how we should do this, I put all my energy into online Parkinson School. This is everything I know. There are no secrets. There is nothing that I tell my patients in practice that I have not said on record on Parkinson School. On the 28th of every month, I teach a 90-minute class on something I think is important. There are patients who tell their success stories. Look how bad I was. Look how good I am now. This is what I do to keep it going. We have an amazing dietitian who teaches a monthly class on protein combining and healthy, cooking on a budget, one-pot meals, eat once, cook for days. Karen Duncan teaches a partner support program. We have a care partner support program, men's group. And then there's certainly the library of basics on, supplements and cannabis and apathy and all the things that we talk about routinely. So I made you all a coupon in case you just want to check this out. If you go to Parkinson School, there's an opportunity to say, I want to enroll to the $10 a month. If you just type in Northwest NWPF, Northwest Parkinson's Foundation, it'll become free. So for anyone who just wants to go and check out Parkinson School and see kind of what we're up to and take a deeper dive into any of these topics, we have an entire 2-hour class on supplements. We've got a 2-hour class on food. Feel free to kind of dabble around in there. All right. Did I really go that? Am I late or fast? What's 1 hour? Perfect. All right. So I'm going to stop sharing and open it up for questions.
Thank you, Dr. Mischley. That was very informative and a lot of good new information I haven't seen presented before. So thank you so much. We're going to open the floor for questions. If you're in the room with us, you are more than welcome to put your camera on and ask questions verbally if you want, or you can use the chat function. If you're in the attendee room and you have questions, please use the chat function. And I know there's a couple questions that have already been submitted. So I can go there first if that's okay. So you were talking about drinking red wine. Is white wine okay? Is that good for you, or what
It's
are your
not
thoughts?
bad. It's not bad. Beer, liquor, and white wine are pretty neutral. There seems to be something a little extra special about red.
Okay. Maybe it's the skins. What do you think of the keto diet? You were talking about the Mediterranean diet.
So ketones seem to be very good for the brain. For the people who don't know, the brain has a couple different ways the body has a couple different fuel sources it can run off of. It can run off of normal carbohydrates, but if you starve it of carbs, it can start burning fat as a fuel. And some of what happens when you burn fat as a fuel, the ketones that get produced are really good for the brain. And so there are a whole bunch of people who have started starving their bodies of carbs to make them start burning fat. So a couple things. Yeah, I mean, if humans are anything like the other animals that we study, ketones are probably pretty good for the brain. However, people with Parkinson's lose weight. And it's one of the scariest things that can happen. When a person starts losing weight, we really, I mean, all hands on deck. That is the beginning of their body. They're losing more than they're gaining. That's the beginning of balance problems, malnutrition, malabsorption. In ketogenic diets, you lose weight. And so most of my patients with Parkinson's, one, I certainly don't need them losing more weight. I already am asking them to make so many dietary restrictions. A ketogenic diet is super restrictive. I mean, it is a really hard thing to sustain. And frankly, most people become malnourished. And so I say, no. I mean, I do ask my patients to not give up the bedtime snack. I ask everyone to do a 12-hour fast every night. So if you go to bed at 10, don't eat after 7 p.m. to 7 a.m., no calories. So you should do a 12-hour fast every night, and you should stop eating 3 hours before bed. But that is not a ketogenic diet. That's intermittent fasting. And that seems to be a nicer, more sustainable way to get a little bit of brain health benefit from tweaking how you eat without going full bore into a ketogenic diet.
Excellent. Thank you so much. This person wrote in that they have started taking a probiotic, Lactobacillus plantarum. I think I said that correctly, for their Parkinsonism, and it seems to be making a small difference. Can you just speak on probiotics and this in general? It's
Yep.
not really a specific question. She just is
Yeah.
asking you what's your opinion and if you can talk on it.
Yeah. So I 100% believe the data is crystal clear that the Parkinson gut is messed up, and the microbiome of a person with Parkinson's is statistically measurably different than a non-Parkinson's person. We can even take a fecal sample from a Parkinson's mouse, give it to a non-Parkinson's mouse, and watch them start to get Parkinsonism. Like, we know that the microbiome is playing a really big role here. We just did a study where we took 50 people with Parkinson's, 50 healthy controls, had their the genetics of their intestinal microbiome analyzed. And there were, I think, 186 different organisms that separated Parkinson's people from healthy controls. So the idea that you are going to, and remember, and when we got people's results back, each person has 5 to 7 million different things growing in their gut. So the idea that you can take one of those bugs or even 5 of those bugs and meaningfully shift what's happening in there is kind of a joke. I mean, it's really a drop in the bucket. If you just did a course of antibiotics, yes, I think you probably should take a pretty hearty dose of probiotics just to get some balance back in there. That makes sense to me. But this idea of taking lactobacillus to slow Parkinson's progression doesn't make sense. First of all, because I think there are 5 studies now that say people with Parkinson's already have too much lactobacillus. In our study, they were way too much. So in this situation, this person could actually be hurting themselves. We know people with Parkinson's are messed up, but they're not necessarily messed up in the way you think. They don't lack lactobacillus the way that a person who just took an antibiotic does. So I think the microbiome is absolutely going to be a therapeutic target. I think I am more excited about things like fecal transplants, and there will be a probiotic for Parkinson's, but we are absolutely not there yet. We don't even know what the differences are. We're not ready to start fixing it. And if you truly want to change your microbiome, the best thing to do is change what you feed it. The bugs that grow in your gut are a function of what foods you're feeding them. The more fiber you feed them, the more you grow the anti-inflammatory bugs. The more cheeseburgers and milkshakes you feed them, the more you grow the pro-inflammatory bugs. And even these probiotic studies and fecal transplants, my fear is that they're going to work really well short term. We're going to give you a whole new microbiome, and you're going to go home and start eating your cheeseburgers and milkshakes again, and all the benefits going to be gone in 6 months because you went right back to growing the old bugs. So save your money on the probiotics for now. Eat your fruits and vegetables and fiber-containing foods, is my opinion. And our data does not say that people who are taking probiotics are progressing slower than people who are not.
Excellent. Thank you so much. This question is this is a good one. Is shellfish a positive food category?
Yep. I put shellfish, non-fried fish, scallops, all of it. Yep.
Okay, great.
Seafood.
Seafood. All right. I don't see any questions, any more questions in the, oh, are you holding a PD school at Bastyr this summer?
I'm meeting with the Bastyr team tomorrow at 4 o'clock and to let you know for sure. But right now, the dates that we have planned are August 19th through the 23rd. And what I will do is I will put in the chat the name of it. We have a little inside scoop list. Anyone, there's a list that we keep for people who said it's kind of like a first right of refusal. Like, for people who just before we open it up to the public, we have a list of people that we send out, hey, we're about to open registration. You reached out to us in the past. Let me say to everyone. So this is Julie's email at Bastyr. Whoever's asking about Parkinson School, if you want to be on the list of, hey, we're about to open registration in the next couple days. Laurie said you wanted to be let in to know about it first. Just send an email to Julie and she'll put you on that list.
Thank you. Any other questions? Anyone in the room have any questions?
Somebody's hand is up. I can't tell.
Oh, is it?
It says it to somebody. There's one hand up. I can't.
Oh, yeah, Kathleen, your hand is up. I can allow you to talk or you can type it into the chat. But maybe. Yeah. I'll allow you to talk if you want.
Yep.
Can I talk?
Sure.
Yeah. Yes.
Dr.
I don't
Mischley?
think you're Maggie, but go ahead.
No, I'm not Maggie. I've recently started using a CPAP that was my wife's old CPAP. And not she anything. I've significantly reduced the number of bad aggressive dreams that I've been having. Is there some foundation of that on that?
Yeah, we talk about nutrition for the body. And I'm talking vitamin C and iron and folate and potassium. We forget how important oxygen is, the most important nutrient of them all. You'd be amazed how much better your cells work when they actually get oxygen. It's amazing. Yes, we have to breathe. Absolutely. CPAPs are if you have sleep apnea, absolutely wear your CPAP. And there are a lot of, for people who have bad night's sleep, if you have not been evaluated, get an evaluation. CPAPs work, and there are some new gadgets that don't require the CPAP. I have patients who have little vibrating finger machines and tape their mouth shut at night. And there are all kinds of clever things you can start to do. So yes, I've seen that before. And it's another overlooked, treatable thing that, it's easy for people to think, oh, my Parkinson's is getting worse. My dreams are bad. It must be the Parkinson's. Or it could just be that you're not breathing properly throughout the night.
Interesting. Okay, good. Thank you.
Mm-hmm.
Thank you. That's a good question. Anyone else? I see a couple more in the chat that have come through. Okay. Are the sheets that you showed available to everyone with the access online?
Yep, absolutely. They're if you go to the diet class, they're all on there. And let me just see if this is the one that I think most of you are probably going to want. But yes, it's all on PD School. And I just pulled the PDF into the chat.
Oh, fantastic. So you can go into the chat and you can download it there. How can I access the recording after the session? So each of these, the Communities of Excellence, PD Excellence are being recorded and they are on the website for Northwest Parkinson's Foundation. I have been emailing out every week the registrants to let them know it's now available and kind of reminding them of the next talk. So you should be getting them from me, and then you can go to our website and get it and view them there. So, oh, I'm excited about this one. So we live in Montana, Dr. Duncan. Is there somebody you can recommend that we can see in the Great Falls area for naturopathic medicine? And I'm going to say one thing. We are having a Hope Conference in Great Falls, Saturday, May 4th. So mark your calendar for the person who asked that question. And we would love to see you there. Registration for that will be opening up soon.
And then there's certainly nobody in Montana who has the level of Parkinson's expertise that you're looking for. Your closest bet and best bet is going to be Karen Duncan, who will be talking on the Inland series in a couple weeks. And she has been working with me for the last couple years. She has the same level of Parkinson's expertise and training. She just does it from the Idaho side. So if, you know, it's worth the car ride if you want someone in person, and most of us practice telemedicine. I mean, I'd say probably 80% of my patients are telemedicine. So the world has changed a lot. You don't need someone in your city to get really good care. I mean, it's nice to once a year see somebody face to face, and Karen's close enough to you that you could probably do that, but telemedicine also works to get these things done.
Excellent. Good question. Anybody else? I know we're a little over time and I want to be cognizant of that. But I want to make sure we have a chance to make sure we get all your questions answered. Oh, and it looks like Dr. Duncan just put her contact information for CD Healing Arts is the name of her practice. Can you tell us how to set that up? Set what up? Telemedicine?
Through the clinic, so we'll, in our slides, my last slide is contact information. And it has email addresses and phone numbers for the Parkinson School and my clinic. So you can, when the
Yes.
slides come, find that all there.
I'm going to put something in the chat. There is a downloadable PDF on our website that you can print out, and it has every person who is speaking, their contact information. So I'm going to put this in the chat now and send it out to you. So you can download that and print that out, and that has everyone's contact information. Let me make sure I don't see any more questions. And if there's no more questions, I will just give you our closing remarks and we can go. All right. Well, once again, thank you everyone for joining us tonight. Next week on Thursday, February 1st at 5:30 p.m., we have Dr. Jenny Chang from Vital Kinesis Physical Therapy in Bellevue, Washington. She's coming to discuss the many ways that physical therapy can help people living with Parkinson's rebuild core strength, improve your balance and agility. She will also provide information on her class called Tai Chi Quan, which is a modified Tai Chi program, and it's designed for people with Parkinson's. This class is offered both in person and virtually and is free in partnership with Northwest Parkinson's Foundation. So you don't want to miss this. Dr. Mischley was talking about exercise, and so this is going to be a great talk to get more information on that. I've also put our website in the chat. We offer health and wellness and exercise classes 6 days a week. So we can help you meet those exercise goals, whether it be virtually or in person. So thank you, everyone. I can see that the chat has gotten busy. I'll just see if there's any more questions. And if not, we will call it a night. Okay. I think that's just all thank yous and accolades to you, Dr. Mischley. So thank you so much for joining us and being a part of this expert speaker series.
My pleasure. Thanks for the invite.
You're welcome. Good night, everyone.
Bye.